Hi everyone, this is Dr. Sumit Jain once again. So, we will be doing the remaining questions of subject based test orthopedics. So, starting from question number 171, which of the following statement is not true about coxa plana? So, first of all we must know what is coxa plana. Coxa plana is the another name of Perthes disease. Okay. So, first to know the answers of this question we must know what are the features of Perthes disease. Let us have a look. So, Perthes disease is basically a osteonecrosis of the proximal femoral epiphysis which occurs during the first decade of life, usually from 4 to 8 years of age. And another thing which is important to know is that here the males are affected more as compared to females, okay, and this disease starts with insidious onset of limp or pain. The leg will be in external rotation and there will be limitation of the internal rotation and abduction. So, this is a very important feature of Perthes disease, that the abduction will be limited. Okay. So, when we try to flex the hip, it will go into external rotation. If you have a look at the X-rays, these are the various stages of the Perthes disease as it progresses. Okay. In initial stages you will see only sclerosis of the femoral head, and then in further advanced stages you will see fragmentation of the femoral head, and in third there will be extrusion of the head out of the acetabulum. Okay. So, the fragmentation of the femoral epiphysis and lateral subluxation of the femoral head will be seen. Okay. So, it is treated basically initially with the help of conservative means. We try to limit putting weight on the leg and will try to contain the head in the acetabulum so that its contour is developed. Okay. So, usually we give bed rest to the patient, avoid weight bearing, anti-inflammatory drugs, and activity of the patient is decreased. If all these things did not help, then we might go for casting in abduction so that the femoral head can be contained in the acetabulum and there is a adequate stimulus for the formation of the femoral epiphysis. If all these things do not help, then femoral osteotomy, varus derotation osteotomy is the treatment of choice. So, if we see it occurs more commonly in females, no, we have just seen that this occurs more commonly in males. Okay. So, this is not true. So, this is going to be the answer. Commonly affect children in first decades, yes, we have seen it affects the children from 4 to 8 years of life, which is first decade of life. Abduction in flexion is restricted. We have seen that abduction is limited when we flex the hip. Okay. And there is a lateral subluxation of the femoral head on X-rays. So, statement B, C and D are true statements. So, only statement which is false is A, which says that it occurs more commonly in female. So, answer of the question 171 is going to be A. Now, let us move on to next question, which is 172. Which of the following is not a feature of CTB shoes? CTB is, you all know, congenital talipes equinovarus. Okay. So, I mean the first feature they have written is straight inner border. Yes, we keep the inner border straight to prevent the varus of the forefoot, varus, or you can say varus of the forefoot at which happens at the metatarsal joints. To prevent that, we usually keep the straight medial inner border or medial border. Outer shoe raise is used to prevent the supination. It prevents the supination and keeps the limb into pronation, which is desired. Okay. Large heel, we never use a large heel in CTB shoes, because if we use that, equinus deformity will again develop. So, the large heel should be the answer of this question number 172, which is C in this case. Have a look at the pictures of the CTV shoes. If you see, this is normal shoes, and this is the one which is used in CTV patients. Okay, so you can see the inner border is straight as compared to the normal shoe where it is little bit curved, and in CTV shoes we have given the outer heel ridge. This is to keep the foot into pronation and to prevent the supination, and we never give a heel in CTV shoes, because if we do that it will lead to redevelopment of the equinus deformity. So, the answer of this question is going to be C. Large heel is never used in CTV shoes. The question number 173, a patient presents with pain and cold insensitivity at the fingertip. Pain and cold insensitivity at the fingertips. There is a bluish discoloration under the nail. The most likely diagnosis is. Okay. Now, this is this scenario talks about something which is called glomus tumor. Okay. So, the bluish discoloration under the nail clinches the diagnosis in this case, because you do not see bluish discoloration in rest of the things under the nail. Okay. So, let us have a look what is glomus tumor. Basically, it is a benign tumor of the glomus body, which is a perivascular temperature regulating structures, okay, around the vessels at the tip of the fingers, okay, and it mainly happens in the subungual region. Okay. So, the classical triad of symptoms is paroxysmal pain, quite a lot of tenderness when you touch this area, okay, and there will be cold intolerance. This is the classical triad which you will see in the glomus tumor. Okay. And if you see physical signs, you will see small bluish discoloration which is there under the nail, and this is seen only in glomus tumor. You will not see this thing in any other pathology related to the subungual region. Okay. So, there are some propagative tests also which will give us an idea that this is glomus tumor only. For that, first of all is Lup test. What we do here is, with the help of tip of pin, we usually press the lesion, okay, and if we do that, that will lead to quite a lot of pain. Okay. Now, other test is Hildreth test. This test, what we do, we inflate a tourniquet, okay, and on the inflated tourniquet, if we try to perform a Love test, means pressing the lesion with the help of pin tip, so that pain will vanish. There won't be any pain when you press the lesion with the help of pin tip. So, this is called Hildreth test. On X-ray, you may or may not see erosions or deformity of the bone cortex. That if has to happen, that will happen because of increase in size of the tumor. MRI will definitely give you a diagnosis, okay, and treatment for this kind of lesion is usually surgical, where we do marginal excision of the tumor. Okay. The another choice which is given here is Tourette tumor. We all know what is neurofibroma, Raynaud's disease, but Tourette tumor is something which is very rare. Okay. So, it can be confused with glomus tumor. So, what are the features of Tourette tumor? This is nothing, basically a acquired osteochondroma or exostosis. Okay. This is also called Tourette's exostosis. Okay. This happens mainly in the proximal and the middle phalanges of the hand, and it usually occurs in 3rd to 4th decades of life. It is a rare complication of the minor injury to hand. Okay. Metacarpals can also be involved. What you will see on X-ray, there will be some subperiosteal bone formation, okay, and this will be mostly below the extensor apparatus, under the extensor apparatus. Now, you can see this X-ray, you can see on the extensor side of the finger, there is little bit of swelling which is arising, and this is nothing was a Tourette tumor or acquired osteochondroma. So, this is basically characterized by pain, soft tissue swelling and growing mass leading to limitation of motion and cosmetic deformity. The treatment of this kind of lesions is excision if they are causing any functional or cosmetic issues. Okay. So next question number 174 is, which of the following is not a recognized treatment of carpal tunnel syndrome? I presume you all know what is carpal tunnel syndrome. This is the compression of the median nerve under the volar carpal ligament in the wrist. Okay, so I have added another choice E, which is not given in your original question, which is yoga, to just confuse you more. Okay, so what treatment is not beneficial in treating the carpal tunnel out of these? So let's have a look at the non-operative and operative treatment which can be done for the carpal tunnel syndrome. If the symptoms are not severe and there is no significant progressive neuropathy, you can go with splintage, the cock-up splint, keep the wrist in extension at nights. Then hand therapy, physiotherapy in the form of ultrasonic massage, anti-inflammatory medications. Then you can also inject a steroid into the carpal tunnel to reduce the inflammation around the median nerve, and even in yoga is helpful for treating the carpal tunnel syndrome. And if you have to go for surgical treatment, which is usually done when symptoms are severe and there is a progressive neuropathy, then you have to release the carpal tunnel, you have to cut the volar carpal ligament. You can do it either open or with the help of endoscopic release. Endoscopic release could be done in any way depending on surgeon's choice. It can be done through single portal, it could be done through this double portal also, but the nerve stimulation therapy has no role in the treatment of carpal tunnel syndrome. So the treatment of so the answer of question number 174 is going to be A. Let's move on to next question number 175. A 15-year-old girl, 15 years old, okay, so this is basically a teenage, complains of anterior knee pain, okay, which increases on going upstairs and getting up after long sitting. This something points towards the patellofemoral joint dysfunction. Patellofemoral. So that is something which comes into action whenever we bend our knee up to 90 or more than 90 degrees. Okay, the most probable diagnosis they are asking. Now the age of the patient is 15 years. And if you are talking about patellofemoral arthritis, that usually will not happen in 15 years of a person. So that will usually happen in the later age or elderly. Okay. Now there could be other things. Chondromalacia patelli, yes, definitely it could be a one of the answers. Plica syndrome could be there. Bipartite patella, this usually is asymptomatic, it will never lead to this kind of symptoms. So D and C are out of question. Now let's have a look what is chondromalacia patelli and plica syndrome. So bipartite patella is a congenital fragmentation of patella and is usually asymptomatic. A plica, what is plica? Plica is nothing but they are the folds of the synovium which pass from they could be either in the suprapatellar pouch, they could be attaching the patella to the femoral condyles, as well as if these plicas or these synovial folds get inflamed, so that will lead to this kind of plica syndrome, where the patient will usually present with meniscal symptoms like locking or pain on extremes of bending. Okay, the patellofemoral arthritis, as we have already discussed, usually happens or occurs in elderly patient. What is chondromalacia patelli? Chondromalacia patelli is basically a disease of teenagers where usually the cartilage under the patella becomes soft. So whenever patient will try to bend the knee, so there will be compression between the cartilage on the patella and the femoral condyle. So already softened cartilage will be compressed and that will lead to pain. Okay, so in this case, where they have said that the patient has got problems in getting up after prolonged sitting, this is nothing but something called movie sign, which is positive in chondromalacia patelli. Okay, so plica syndrome is not the answer of this question. Chondromalacia patelli, because 15 years old girl, movie sign is positive, difficulty in going upstairs involving the patellofemoral joint is nothing but chondromalacia patelli. So, answer of question number 175 is A. Let's move on to next question 176. Which of the following are the benefits of immobilization of a fracture? Now, whenever a bone fractures, definitely it will injure the soft tissue around it, because if a force can break a bone, it will definitely injure the soft tissue through which it is passing. Okay. So, when bone will fracture, there will be sharp ends of the bone. Those sharp ends will further damage the muscles, and all that muscles will go into spasm, and that will lead to pain. If you immobilize the limb, there won't be further movement at the fracture site, there won't be further spasm, so the pain will be less. So, yes, it helps in reduction of the pain. Another is chances of fat embolism. Now, whenever we have a close fracture of tibia or femur, so our bone marrow is full of fat globules. So, whenever fracture will happen, the fat globules will be available or will be present all around the fracture sites. So, if the fracture is closed and continuous movements are present at the site of fracture, so that will push the flat globules into the blood vessels. They will go to our right heart, and then they can go to our lung, and they can lead to fat embolism. If we immobilize the limb, there won't be any further movement at the fracture site, there won't be any increased fracture at the fracture site. So, the chances of fat embolism will be reduced. So, yes, immobilization or splinting will reduce the chances of fat embolism as well. Reduce the chances of further injury to the neurovascular structure. Yes, it will also reduce the chances of neurovascular injury, because bone is a hard and sharp structures. So, if the fracture keeps on moving, nerves and vessels passing around that area can be injured. If we immobilize the fracture, those movements will be stopped, and the chances of further injury to the neurovascular structure will be prevented. Okay. There is another benefit which is not written here. If we have to shift the patient for x-rays and all that, that becomes easy. Now, Now, imagine if his leg is dangling or moving like here and there when the patient is going on a stretcher. So, that will lead to quite a lot of pain, and patient may not allow that. So, transportation of the patient also become easy. So, these are the benefits of immobilization. Now, he is asking in this question which of the following are benefits of the. So, all of above are the benefits of the immobilization. So, answer to the question number 176 is going to be D. Okay. So, next question is 177. A patient was operated for forearm fracture. So, fracture over radius and ulna somewhere under general anesthesia under tourniquet. So, tourniquet was applied. Following surgery, after the surgery, he was unable to move his fingers. Seems like some sort of nerve has been injured, and no regional anesthesia was given, and patient was given general anesthesia. So, as soon as he comes out of anesthesia, he should be able to move his fingers. Okay. But here patient is not able to move his fingers. Okay. And there is a sensory loss over the whole hand. So, the whole hand, I mean, we know that the nerve supply which gives sensation to our hand includes radial nerve, median nerve, and ulnar nerve as well. Okay. So, all the nerves seem to be damaged. That is what happened in tourniquet palsy. So, it appears that this patient has got tourniquet palsy. Okay. Now, and whether what kind of injury happens in tourniquet palsy, whether it is neuropraxia, exantemesis or neurotemesis. Okay, let us have a look at the various nerve injuries. Now, this is a picture, and the first one where you can see the different layers of the nerve. So, we have a endoneurium here, okay. We have a perineurium and epineurium. Okay. Now, here the structure of the nerve in neuropraxia remains intact. Okay. There is no structural damage to the nerve, only functional or physiological disruption in the nerve conduction as it happens in the tourniquet palsy. Now, the pressure comes over this area, okay, and that will prevent that will stop the conduction of the nerve. Okay, that's happen in tourniquet palsy, Saturday night palsy and crutch palsy. The other injury is axontemesis. Here the name suggests that axon means there is a damage and temesis means to cut. Here there is a damage to the axons. Now this kind of injury happens when there is a kind of pull to the limb. Let us say we have a fracture of the humerus and we are giving kind of traction to the humerus, so that will pull the nerves and that will damage only the endoneurium. So rest of the perineurium and epineurium will remain intact. Okay, the third type of injury, this usually happens due to cutting of the nerve, is called neurotemesis. Temesis means to cut, neuro means to nerve. Here all the three layers, endoneurium, perineurium and epineurium, are cut. The chances of recovery of this nerve are very less unless we repair the nerve and bring the tubes together. Okay, so in tourniquet palsy, Saturday night palsy and crutch palsy, usually neuropraxia to the nerve happens. So the answer of the question number 177 is going to be A, neuropraxia. Okay. Now question number 178, fallen fragment sign is characteristic of ABC, aneurysmal bone cyst, SBC, simple bone cyst, giant cell tumor and Ewing sarcoma. Now fallen fragment sign is seen in simple bone cyst. Okay, and what do I mean by that? Let us have a look. Simple bone cyst is also known as solitary bone cyst or unicameral bone cyst. It usually affects the children between first and second decade of life. It arises in the metaphysis and most common sites are proximal humerus and proximal femur. The simple bone cyst will contain serous or serosanguinous fluid. Okay, and on X-ray it will be seen as a osteolytic expansile lesion. Okay, and that will lead to thinning of the cortex. So if this kind of bone where the cyst is present, simple bone cyst, ruptures, so that will show a fallen fragment sign, which can be seen very nicely here. Okay, so the fallen fragment sign is seen in simple bone cyst. The question 178 answer is B. Okay, let us move on to question number 179. Adams test is done for. So the choices are for thoracic outlet syndrome, to differentiate between structural and postural scoliosis, to check the perfusion of the hand, to check the progression of the nerve regeneration. I presume we all know that the test to check the progression of nerve regeneration is called Tinel's sign. Okay, and the test to check the perfusion of the hand is called Allen's test. And for diagnosis of thoracic outlet syndrome, there are various tests. Let's have a look at the names of the test. To diagnose thoracic outlet syndrome, we have Edson's test, Roux test and Wright's test. To check the perfusion of the hand, we have Allen's test. What we do here, we compress both the arteries, ulnar and radial artery, and release one by one to see which artery is functioning, which is giving better perfusion to the hand. And regeneration of the nerve is usually checked by Tinel's sign. And the Adam test is something which is done to differentiate between structural and postural scoliosis. Now we all know postural scoliosis is something which happens when, let us say, we have a shortening of the one limb. Okay, so the pelvis will tilt and that will lead to scoliosis. Okay, so if we make the patient bend forward, if the scoliosis is postural, that will disappear, the spine will become straight. Okay, and if the scoliosis becomes more prominent on bending forward, then definitely that is structural scoliosis. Okay, the functional scoliosis will disappear on forward bending, while structural scoliosis will not. Okay, so the Adams test is done to differentiate between structural and postural scoliosis. So answer to 179 is going to be B. So question number 180. Most common cause of EVN of hip is idiopathic alcoholism, Cashion's disease, fracture neck femur. All these the choices given are causes of avascular necrosis of the hip. Apart from that, there are few other causes also, so which can be divided into traumatic and not traumatic causes. Various fractures around the hip can lead to avascular necrosis, but some other diseases are also there. If we cannot find any of these diseases which is leading to avascular necrosis, then we term it idiopathic. Idiopathic means we do not know what is the exact cause, and in most of the cases of AVN which we see in the clinical practice, the cause is not obvious. Okay. So, the most common cause we term it as idiopathic for avascular necrosis of the hip. So, answer of the question 180 is going to be A, idiopathic. Okay. So, the question number 181, which of the following is not true about osteoid osteoma? So, this is the most common true benign tumor of the bone. Yes, this is the true benign tumor, because osteochondroma is not a tumor, this is a basically growth aberration. So, osteoid osteoma is the true benign tumor of the bone. It occurs between 10 to 30 years of life. Yes, we can say that usually happens in this age. Lesion appear ill defined on X-ray with permeative margin. I do not agree with this statement. Usually the lesion on osteoid osteoma is very much well defined. So, we can't say that this is ill defined. Okay. The other choice is bones can shows increased uptake in the lesion, that is also true. So, basically if you see the osteoid osteoma, the lesion is very much well defined, you can see. So, and the size is also sometime permanent, fixed, that this is of this size. So, the lesion is well defined. So, I think the choice C is the answer of question number 181, where it has written the lesion appears ill defined on X-ray with permeative margin. So, this statement is not true. The answer of question number 181 is C. So, next question 182, which of the following is not a feature of tuberculosis of the spine? Okay. So, we all know tuberculosis of the spine usually a paradiscal type. When it happens, it will lead to lot of inflammation which will create pain in the back. So, pain in the back is going to be the earliest symptoms, and then it will lead to spasm of the muscles and will restrict the movement of the spine because of involvement of the vertebral bodies. So, yes, exaggerated lumbar lordosis doesn't seems to be right. Cold abscess, yes, we can see cold abscesses. So, why this doesn't seems to be right? Let us have a look at various type of tuberculosis of the spine. So, these 4 are the types of tuberculosis of the spine. Out of these, most common type is paradiscal type, where the half of the vertebral body above, half of the vertebral body below, and the whole disc gets involved. So, when this kind of lesion happen, there will be collapse of the vertebral body, and that will be lead to kyphosis. Okay. Another type is central, which happens in the center of the vertebral body. If this vertebral body also collapses, so that will also lead to kyphosis, not lordosis. And another is anterior type, where the anterior elements or anterior vertebral bodies or this type of lesion happen behind the anterior longitudinal ligaments. If these lesions happen, it will also lead to kyphotic deformity. The last type is posterior, where the posterior elements will be damaged. So, yes, this kind of lesion sometimes can lead to exaggerated lumbar lordosis, but this is a very rare variety of tuberculosis involving the posterior element. The most common type is paradiscal, followed by central and anterior. So, we will go with the common things you can see in next picture. So, if this area collapses, so what will happen? There will be kyphosis. Okay. So, there will not be any lumbar lordosis. So, the answer to this question should be C, exaggerated lumbar lordosis. Okay. So, the answer is C. Now, question number 183, 62-year-old man present with persistent pain over the left big toe. Now 62-year-old male, usually the patients with this age will have osteoarthritis, okay, of the various joints. He has got pain over the left big toe. Left big toe pain could be due to gout as well, okay. On examination there is swelling, there is swelling is there, but no redness or no increase in temperature. So this goes little bit against gout, because in gout we usually see there is a redness, increase in temperature, okay, and decrease in range of movements over the first metatarsophalangeal joint. This can happen both in gout and some other diseases, okay. So gout, yes, could be one of the answers, okay, and hallux rigidus is osteoarthritis of the first metatarsophalangeal joint, so which will lead to pain and restriction of movement. So that also fits into the presentation. Morton's neuroma will not lead to pain over the great toe. It will lead to second or third toe pain. How? I will show you later on. Stretch fracture, again it happens usually in the second metatarsal, so it will not lead to pain in the metatarsophalangeal joint, where they have seen he has got restriction of the movements, okay. So our answer has to be either this or this, but because there is no increase in temperature or no redness, our answer should be B, hallux rigidus. Let us have a look at these four entities. Gout, you will see this kind of redness and swelling in the metatarsophalangeal joint. In hallux rigidus, which is osteoarthritis of the first metatarsophalangeal joint, there will be swelling, yes, there will be restriction of movements, and the movements will be painful, okay. So this fits more into the answer. In Morton's neuroma is nothing but neuroma of the interdigital nerve. It happens either here or here most of the times. So if that happens, so that will lead to burning sensation around these three toes, but not in this area. The stretch fracture usually happens in the second or third metatarsal. This is also called a march fracture. This will also not lead to restriction of movements of first metatarsophalangeal joint. So our answer has to be hallux rigidus in this case. For 183 it is B. The question number 184, a 13-year-old girl complains of backache and fatigue. Teenage girl, backache and fatigue, okay. Her mother has noticed that she is becoming increasingly round shouldered, means she is becoming kyphotic. On examination she has smooth thoracic kyphosis. X-ray shows wedge-shaped vertebral bodies in thoracic spine, okay. So intervertebral disc prolapse, if it has to happen, it usually will happen at a single level, and it is common after the age of 20, not very common in teenage girls, okay. So and moreover that will not give kyphosis, that will usually lead to spasm of the muscles, and lordosis will be increased. So intervertebral disc prolapse is out of the question. So spinal stenosis, again this is a disease which happens in elderly patient because of arthritis of the facet joints and formation of osteophytes and hypertrophy of the ligaments. Here the patient is of 13 years of age, so I won't consider spinal stenosis either. Ankylosing spondylitis could be there, but that will lead to other symptoms first, like involvement of the sacroiliac joints, and again seeing them in 13-year-old age girl is not that common. So we are left with a choice called Scheuermann's disease. Let us have a look what is Scheuermann's disease. This is also known as adolescent kyphosis. Patient will have fixed round back deformity. There will be wedging of the several vertebrae, yes, as you can see in this picture, okay. Why this happens? Basically there is a defect in the cartilaginous end plates, okay. These end plates, they are defective. So whenever the patient will go for the sports activity, the disc will protrude inside the vertebral bodies and will lead to wedging of the various vertebrae, okay. So when the disc protrudes inside the vertebral bodies, that is known as Schmorl's nod, okay. Now it's usually common in females, teenage females. You will see backache and fatigue, there is smooth thoracic kyphosis, and there could be, because of prolonged deformity, there could be spastic paraparesis of the limbs or cardiopulmonary dysfunction. So it appears to be Scheuermann disease, as this is 13-year-old girl, there is a round shoulders, thoracic kyphosis is there, wedging of the vertebra, which is all features are consistent with Scheuermann disease. So the answer of question number 184 is going to be A. Let's move to next question 185. A 16-year-old boy, teenage boy, complains of painful knee during exercises. He is painful only during the exercises, has got a tender lump over the tibial tuberosity. The most probable diagnosis is prepatellar bursitis, Osgood-Schlatter's disease, Pesson serous bursitis, meniscal cyst. If we have a look, now he is having swelling over the tibial tuberosity. In prepatellar bursitis, will have swelling over the patella, not over the tibial tuberosity. Okay. Meniscal cyst will be in an area where you will see a meniscus, and usually tibial tuberosity is anteriorly, okay, and there is no meniscus in this area, so you won't see any swelling in this area. So meniscal cyst is also out of question. Okay. Now the other thing is Pesson serous bursae. It usually happens when where the hamstrings are attached to the tibia on the medial aspect of the proximal tibia. That bursa can get inflamed and is called Pesson serous bursitis. Okay. That will also not give us a swelling over the tibial tuberosity. Okay. So the only thing which give us a swelling over the tibial tuberosity is Osgood-Schlatter's disease, which is traction apophysitis of the tibial tubercle. Okay. More common in older children. In our case, the patient is of 16 years. Okay. Pain felt on direct palpation of the tibial tuberosity, on straight leg raising against resistance, and during the sports activities. And we can palpate a lump over the tibial tuberosity. Okay. And this kind of pathology usually recovers spontaneously, but we should advise the patient to reduce the sports activity. Okay. So the answer of this question is going to be Osgood-Schlatter's disease. Okay. That's all for this session. Rest of the question we'll do in the next session. Thank you.